Let me take you back to this article in 2009. We looked at 1 million patients from the NCDR registry in US. They looked at the diagnostic yield of elective coronary angiogram. And what did they find? They found that 40% of patients who underwent a coronary angiogram had near normal coronary arteries. Only 40% had significant coronary artery disease. So a huge amount of patients being unnecessarily subjected to coronary angiogram. How do we reduce that? So CT angiogram has been performing as a gatekeeper for invasive coronary angiogram over the last 20 years or so. Like CMR, which Dr. John alluded to, it's a gatekeeper for invasive coronary angiogram. It reduces the need for unnecessary invasive angiograms in patients who we suspect to have coronary artery disease. There are certain limitations of CT angiogram pertaining to the fact that patients can have variable heart rates, can have artifacts related to motion, artifacts related to breath hold. And calcium has been the bane of interventional cardiologists. It also has been the bane for cardiologists who interpret cardiac CT. If you have too much moderate or severe calcification, that reduces the yield of a CT angiogram. So what is the best modality for looking at patients who have stable coronary artery disease? How do you identify them? Is a functional testing with nuclear perfusion imaging or a pharmacological stress imaging superior to anatomical testing with a CT angiogram? That was the basis of this trial called the PROMISE trial, which randomized patients, about 10,000 patients, to the anatomic strategy with CT angiogram, and on the other hand, to the functional strategy with exercise testing or pharmacological stress imaging. And what did you find in 1 year? That both the CT angiogram as well as the functional imaging perform nearly equally. The outcomes of, as well as secondary outcomes of death or non-fatal MI was concerned, both of them were equally matched, showing that neither of them was superior to the other modality. Now all of us know that invasive FFR is the way to go when you are dealing with intermediate coronary stenosis on invasive coronary angiogram. The FAME group of trials and the DEFER trials have established the role of invasive FFR testing in patients who have borderline intermediate stenosis. It also determines the way a patient performs after doing an angioplasty, as shown by the DEFER trial. Now here is a way we can combine both anatomical testing and physiological testing by use of this modality called CDFFR. And CDFFR, by the way, combines physiology and anatomical testing in the same time, completely non-invasively. That's the beauty of this modality called CDFFR. And the important thing is you can measure the FFR along the entire length of the coronary tree and also tells you at the point of time which lesion is significant or not. Now, how does CTFFR, how is it done? It's a very complex process. I'm going to make it very simple for you. It's done by, you get 3D images from the CT angiogram, you transfer it onto an off-site computer, a supercomputer, which does this physiologic modeling and also does this called this computational fluid dynamics of coronary blood flow and creates this color-coded 3D mesh of FFR CT. The color-coded red shows a significant of FFR less than 0.75. The color-coded blue shows that it's not significant FFR of above 0.8. It's not simple. So these are the ways it's done. It's an image-based modeling, the segmentation of patient-specific arterial geometry. There are heart vessel interactions looking at allometric scaling laws, relate caliber to pressure and flow. There's microcirculatory resistance involved. There are morphometric laws which relate coronary dimension to resistance. Left ventricular mass is compounded because you know the coronary flow depends upon the coronary mass, the cardiac mass. The lump parameter model which couples pulsatile coronary flow to time-varying myocardial pressure. Physiologic conditions like blood is a Newtonian fluid adjusted to patient-specific viscosity. Induction of hyperemia, which computes maximal coronary vasodilatation, and fluid dynamics, which calls the Navier-Stokes equations applied for coronary pressure. All these complex, vessel interactions, the microcirculatory interactions goes into making the supercomputer which comes out with the derivation of the CT FFR. This is how it's done. As I mentioned before, if the FFR is less than 0.75, it's color-coded red. The FFR is more than 0.8, it's color-coded blue. And the intermediate range between 0.76, 0.8, it's colored yellow. Now, where should FFR-CT be measured? All of us doing invasive FFR, the position, the pressure sensor distal to the coronary, to the lesion site. And FFR-CT is measured 1 to 2 centimeters distal to stenosis, which correlates best with the lesion-specific ischemia. Because FFR is measured along the entire length of coronary tree, you have an FFR value before and after the stenosis, you minus the FFR value distal and proximal, you get a value more than 0.12. It also has higher specificity for detecting lesion-specific ischemia. Now, this is an example of a patient who had a proximal LAD lesion. FFR was measured 2 distal and came out as a positive value of 0.72. When we measured 2 centimeters distal to the lesion, we got a value of 0.82, which correlated with the invasive FFR. It's important that you measure FFR just around 2 centimeters distal to a coronary stenosis for its accuracy to be present. Now, who are the patients who actually requires FFR-CT? The low-risk patients do not need any further imaging. Less than 30% stenosis, they can be tried optimal medical management. The patients with high-risk anatomy, the LMCA more than 50% stenosis, or approximal LAD more than 70% stenosis, or 3-vessel disease, they would immediately go to the invasive coronary angiogram. There are patients with the intermediate risk anatomy, borderline stenosis between 30 and 69%, who would actually benefit from this FFR-CT. This is a table which shows how it's done. Low-risk anatomy, less than 30% stenosis, medical management. High-risk anatomy, invasive coronary angiogram. Patient intermediate risk anatomy, we do FFR-CT, and then if the FFR value is less than 0.75, you triage them to the invasive coronary angiogram group. FFR value is more than 0.8, it's medical management. The FFR value is between 0.676 and 0.8. In the gray area, one group of patients can be tried in the optical medical management and 3-month follow-up looking at symptoms. If the patient develops symptoms, you can subject them to an invasive coronary angiogram. Other group of patients can be managed based on the vessel, the plaque characterization. You have a high-risk plaque as noticed by a spotty calcification or a positive remodeling, a low attenuation on CT, and also as well as all these characteristics determine as a high-risk plaque. If it's a high-risk plaque, you subject them to an invasive coronary angiogram. Now, this is examples of how patients, how a FFR-CT is done. Here you have a CT angiogram on the left-hand side, which shows the mild disease. CT FFR shows a value of 0.91. Invasive FFR shows a value of 0.89. Similarly, a patient with circumflex lesion, again, looks borderline on CT. Again, the value is 0.91. On invasive FFR, also it's 0.91. The example of a patient who had a critical lesion, the LAD, it looks critical on the CT angiogram itself. FFR showed a value of 0.64, which correlated to the invasive FFR value of 0.72. Circumflex, again, the mid-circumflex shows the critical lesion on the CT angiogram, and the invasive FFR also showed a value of 0.52. CT FFR showed a value of 0.61. This shows that how beautifully the CT FFR value correlates with the invasive FFR value. So this is an example of a lesion-specific ischemia on the LAD. It looks critical on the LAD, the CT angiogram, and again, we do FFR, the value came to about 0.72, which is considered significant. So what is the advantage of CT FFR? Addition of FFR-CT to coronary CT angiogram improves the specificity by evaluating lesion-specific ischemia, enhances role as the gatekeeper for invasive coronary angiogram by decreasing non-obstructive disease invasive coronary angiogram, and offers guidance for revascularization, decisions, and planning. FFR-CT has a higher accuracy than CT angiogram. If your CT angiogram accuracy is about 0.82%, by adding FFR-CT, your accuracy goes up to 89%. And also, it's comparable accuracy to CT perfusion. FFR-CT has a superior specificity than CT angiogram. if your CT angiogram specificity is about 50%, by adding FFR CT, your specificity goes up to 70%. So by having FFR CT at site, you're not only increasing the accuracy of CT angiogram, but also increasing the specificity of a CT angiogram by having FFR CT available at the patient site. This is an example of a patient with a moderate lesion in the mid-LAD, and FFR CT came as a borderline 0.78. And because of distal lesion, the patient was kept on optimal medical management. So how does FFR CT help you in procedural planning? This is a patient with triple vessel disease. You can notice that the LAD has a critical lesion. FFR angiogram showed a lesion of the FFR value of 0.71. The circumflex again had a FFR value of 0.72. RCA had a borderline FFR or less of insignificant FFR of 0.86. So both as LAD and circumflex were subject to angioplasty based on the FFR value. RCA was kept on medical management. This is how FFR helps you in planning your strategy, particularly when you have multi-vessel coronary artery disease. So as all modalities, there are some pitfalls of FFR CT. This patient who had a borderline stenosis of the RCA on the CT angiogram, FFR value was all the way abnormal right from top to end. So this is the fallacy of a FFR CT. And again, in a patient who had a mild stenosis in this particular lesion, FFR value was kind of positive. It went on to show that the FFR value, if measured too distal, can be falsely positive. Again, a patient who had a critical lesion in LAD, FFR value came negative. So there's some pitfalls of invasive CT FFR. It's important that you correlate the anatomical CT with the FFR value before you make a final diagnosis. So if you have a diffuse disease, you can notice the FFR value decreases as you go down the coronary tree. FFR value was beginning was 0.98. As you come down the coronary tree, FFR value becomes significant. This shows that the patient has severe diffuse coronary artery disease. Again, if you have serial stenosis, FFR CT has a incremental value because in this patient with LAD lesion here, the proximal LAD was kind of thought to be significant on CT angiogram. The FFR value was 0.93. The mid-LAD lesion was again significant. FFR value was positive, 0.63. It means that you need not intervene on the proximal LAD, just intervene on the mid-LAD. That is because of the FFR CT in this particular patient. What about calcified lesions? As I mentioned before, calcified lesions has been the bane of interventional cardiologists, as well as has been the difficult to interpret as far as CT angiogram is concerned. If you have a diffuse coronary disease with calcification, if you have FFR value of 0.6, it means that the lesion underlying the calcium is significant and needs to be intervened. These are the pitfalls of FFR CT I mentioned before. And what are the trials which show that FFR CT, the correlation of FFR CT with invasive FFR? The number of trials called the Discover Flow trials, de facto trial, NXT trial all showed that the FFR CT correlated beautifully with invasive FFR. Also, it was superior to conventional CT in depicting the severity of coronary stenosis. If you compare all the imaging modalities, maybe and if the gold standard the invasive FFR, what comes close to the gold standard is the CT FFR. All of the modalities like SPECT, CT angiogram are far inferior as far as specificity and sensitivity of this imaging modality is concerned. Now, so if you have FFR CT values which is significant, what is the outcome of patients? This has been studied in two trials. One trial called the platform trial, and another registry called the advanced registry, which trials patients who had a FFR CT, in one in the FFR CT negative arm and FFR CT positive arm. And they followed up these patients for a year. And what did they find? The patients with FFR value of less than 0.8, they had adverse events, the death, MI, ACS, leading to unplanned revascularization was significantly higher in the FFR CT arm, which was significant compared to FFR CT value of more than 0.8. When death and MI was also significantly inferior, significantly disadvantageous in patients with FFR value of less than 0.8. This is how FFR CT report is given. You have the anatomic assessment, you have the physiologic assessment, and you have the plaque burden, which tells you the high-risk plaque. All three findings in one single report: the anatomic assessment, the physiologic assessment, and the plaque characterization based on the CT angiogram alone. Now, come back to this trial, which is called the PRECISE trial, which was recently presented in the American Heart Association meeting in this year by Dr. Pamela Douglas. Here, the patients who had a stable chest pain were triaged into two arms. One arm was the precision arm based on the PROMISE risk scores. They underwent CT FFR and CT angiogram. Other arm was a conventional testing with nuclear perfusion or a stress perfusion, and the patients were followed up for a year. And so what did they find? There was 70% decrease in the primary outcomes of death or MI in patients who were triaged into the FFR CT arm. So ladies and gentlemen, we conclude by saying that FFR CT is a physiologic simulation technique that uses routine CT angiogram data to mathematically model coronary flow pressure and resistance. The addition of FFR CT to CT angiogram improves the specificity by evaluating lesion-specific ischemia, enhances role as a gatekeeper for invasive coronary angiogram by decreasing non-obstructive disease at invasive coronary angiogram, and offers guidance for revascularization decisions and planning. FFR CT value greater than 0.8 is normal, 0.76 to 0.8 is borderline, less than 0.5 is abnormal. Interpretation of FFR CT should not be done in isolation, but in correlation with other factors including history, symptoms, comorbidities, and location of abnormal FFR CT anatomy. FFR CT is the most useful in the intermediate risk patients who require further decision making. I want to thank each one of you for your patient hearing. Thank you very much.